So there's been a lot in the media around prostate cancers, PSA testing, screening, and a call for more robust screening programs or actually introducing the screening program in the first place. I know you've recently done a piece on in the Telegraph as well, and I think for the audience it would be quite interesting to get an understanding of what the barriers are, what the risks are, and also do we need a screening program in the first place for prostate cancer?
Okay. So I think just so that we're all on the same
Yeah.
page, let's do a little bit of basic overview and then go into it. Typical GP, isn't it?
Yeah.
So we know that most of the time when a PSA is raised, it turns out not to be prostate cancer, right? We know that objectively. I think the actual number is something like 75% of raised PSA doesn't turn out to be prostate cancer. We know that of all the patients with prostate cancer, at least 15% have a normal PSA. So it's not hugely specific or sensitive, right? Like as in so what we're saying is it misses cancer, and when it suggests cancer, it's often wrong. That's a
Yeah.
fair summary of the PSA, but it's all we have. So that's the reality of where we are. So as a tool, it's never been used as a screening test, probably for fair reason. Then you look at what do we understand about prostate cancer today compared to in the past. So prostate cancer in medical school was described as the cancer that you die with, not from. That was always our understanding of prostate cancer, right? It's this, and I'm going to be overly simplistic here, it's this relatively benign, harmless thing that people have that you kind of don't need to worry about. That was the general overview of prostate cancer. And that's because a very small percentage of it was thought to be aggressive and metastasizing. But in reality, I've always been surprised by the amount of palliative prostate cancer I've seen or the amount of prostate cancer that's metastasized. And I'm just like, this isn't really my understanding of it, right? And I don't know whether that's because we understood it wrongly, because maybe research takes so long to change the way medical schools teach students about it, or whether there's just been a shift. Because sometimes cancers just change the way they behave. And the thing that I found really interesting is obviously Rishi Sunak did a piece on this and David Cameron did a piece on this. And there's a lot of patient advocacy about it. And I did a piece on the radio about this as well. So one very specific nuance that, for example, has become quite well known is that people from the Black community especially tend to develop prostate cancer at least 5 years earlier than all other cohorts, right? That's number one. So they develop the condition earlier. The other thing is, on having the condition, they're more likely to have an aggressive metastasizing version of the condition.
So they're not only having it earlier, they're more likely to have
an aggressive form, which they're likely to then die from, right? So there's one conversation about whether you do something more generally for prostate cancer screening, and then there's probably a separate conversation about doing something for targeted communities. I think these are two separate chats. So if we started with the general screening principle, right, what is the purpose of screening? It's to find something that you can do something about, and that something should be meaningful. So I am a strong advocate for prostate cancer screening. And the reason is, when we do smear tests, we're not even looking for cervical cancer. We're looking for pre-cancer changes. Now, I would agree that if somebody has cervical cancer, it's always a bad thing. Like cervical cancer is not one of those things that you grow old with. It's a highly metastatic cancer. So I get there's a different urgency to it. But I think we have precedent of finding stuff before it becomes something. And we know increasingly there's an increasing metastasizing, advancing cancer type risk. And I think a PSA test is a really, really cheap way of testing that. It doesn't take much. Do you know what I mean? You can do PSA testing with no appointment. Realistically, you just could educate patients, have a consent process. Whereas if you want to do cervical cancer screening, you need a nurse appointment. It takes 15, 20 minutes. There's a smear.
Physical examination.
There's a physical examination. It's uncomfortable. You need to wait for results. But a blood test, it has such low barrier to entry, right? And I would instead focus on developing a test that's more accurate, that's more sensitive, that's more specific. I think that should be a higher focus rather than let's not do the test. So that's number one. The other thing is, when the prostate cancer screening recommendations were refused originally, the thought process was when somebody has a raised prostate-specific antigen, they're going to then need a biopsy, which is a needle into the prostate. And obviously risk of infection, pain, bleeding, etc. So it was felt that you're doing something very invasive that's very uncomfortable for a condition that's more often than not going to turn out to not be an abnormal condition. It's just going to be a normal prostate finding. But in today's society, we don't really do that. So in today's society, when somebody has a raised prostate,
We do scans.
we do an MRI scan. And so there's very little reason for me to not consider prostate screening, because these people aren't going to end up with a biopsy. They're going to end up with an MRI scan. And an MRI scan is highly sensitive for finding prostate cancer. And in those cases, you could then do the biopsy. Now, I'm not saying put every man over a certain age through an MRI, which really is going to be the ideal scenario, right? But just from a practicality, resource perspective, obviously that's not possible. But what you could do is you could screen them with a PSA, and then the ones that are positive, rather than subjecting them to a biopsy, you could send those ones for an MRI scan. And then we could do with the data. We could do with the data on this percentage of people with a raised PSA go on to have an abnormal MRI scan, or this is how much time it saved, money it saved, cancer it's avoided, etc. And then I think there's a separate conversation when you know there is a cohort of people that develop a problem sooner, more aggressively, and are more likely to die from it. I think even if we didn't do something for prostate cancer screening, I struggle to conceptualize the rationale for not testing the Black ethnicity population.
Yep.
I struggle with that. I don't understand what the rationale is when these people develop the cancer sooner and they die from it more often. How do you justify not screening at least this cohort at a minimum? And I think you could even look at that as a phase one. You could look at that as, well, let's do it where it's really needed. And then let's have a look at how effective it is and what the lessons to learn are. And then let's roll it out perhaps. But the issue I have is our current stance seems to be, and what I've heard, I don't think it's 100% confirmed, but what I've heard so far is kind of a no. The position seems to be a no, with just, well, it's not cost effective or it's not practical, and the nuances aren't taken into account.
What I found quite interesting talking to you in terms of the other topics is how you bring it back to the surgery that you're working with. So looking at your day-to-day, looking at consultations that you may have had with patients, how do you frame that? And what have been the concerns patients have raised when it comes to the worry about prostate cancer, PSA testing? Because naturally, as much as we read the media, they read it as well.
I mean, so the patients want it, right? The patients want a PSA. And here's the thing I find this really inequitable, right? Because if a patient was to message us and say, I want a PSA, and they're above a certain age, what reasonable reason do we have to say no? Realistically, right? If you're a man over a certain age and you want a PSA test, you'd have to be pretty certain as a GP that there's no justification to do that blood test. Because unless you've seen them in person and examined their prostate, or you've gone through a full history with them, which has then required a consultation, right? You've required a consultation to then tell them no. Like, how many people are doing that? So you're gonna use a consultation with a highly skilled member of the team to say no for something that a person is anxious about because a family member's died of prostate cancer, or they've read that somebody famous on the news has died of prostate cancer, or something like that. Most people are going to say yes to that, right? And all you've done is you've used a consultation, I would say wasted an appointment, to put it very, very frankly, in a system that's struggling for appointments, to then give them what they asked for. And why not instead just let them make an informed decision and just direct them to a website when they make a request, or send them a message to say, please read this information and answer these questions to show that you understand what it is that you're asking for. Demonstrate to us that you understand that in 3/4 of the scenarios when these people go on to have testing, when the PSA is raised, it turns out not to be cancer, and you have the complications of the procedure, and we miss some signs of cancer. And if they understand that and they accept it and they consent to it, give them the test. And that's what we would do. So the only question really is what to do about the people that haven't heard about prostate cancer, or don't know to ask for a test, or don't feel comfortable asking for a test. Those are the only ones not getting the test, because anybody that feels comfortable talking about it and asking for it is probably going to get it. So really what you're saying is, if somebody feels embarrassed, or if they don't have the level of education other people have, or they don't have the level of exposure, you find with them missing out on the opportunity, which I think is a health inequality issue. And that might sound very strong, but I feel quite passionately about this.
I think it's important to have these strong conversations, because if we just go around the topic and talk about it, it causes confusion, and that confusion then transpires to the patients, who then request it, and then the clinicians are confused. So I think it's important having these strong conversations. It also opens up a whole nother avenue, because if we're looking at screening as a whole, just a few minutes ago we were talking about precursor illnesses, we're talking about pre-diabetes, it opens up a whole conversation. So from your point of view, where do we start screening, and how much can we screen? And where's the limit? Do we need to have certain barriers? Where do we go with this?
I disagree with this on an ethical basis, right? Because I think, I'm not a politician, right? And I'm not in control of the budget. And if they want us to take that into account, then they should incorporate management and finance into our training, right? Like,
Yeah.
I'm not trying to be flippant about this. We don't get management training. We don't get finance training. We're trained to treat illness.
Yeah.
So that's what we should talk about. We should talk about treating illness. And I think, if they want us to care about budget, then put us in a position. Then take some doctors and put them in some sort of parliamentary positions where we have control over these things, and then we could rationalize some of these things in view of finance. But until then, I'm just going to talk about what's good, because that's what we're supposed to do, right? So to me, it's not. I don't think it's my job to go find the pots of money to figure out how to do screening programs. I think it's the country's job to figure out how it should do a screening program. And I think my job is to say whether or not a screening program is a good idea. And if you're not going to do it here, at least do it for this patient. That's my job, right? So my job is to educate the public, and is to give my professional opinion. And if we are saying that we can't afford to do a screening program, okay. But my question is, have you considered the amount of time when you miss these cancers, what it then costs in surgery costs, what it costs in care home fees, and what it would cost you to do a single blood test? Have we done a comparison in terms of, and I'm not sure we have, in all honesty. But if we have, and it doesn't make business sense, okay. That's not for me to decide, right? And I think we overcomplicate this. We try to turn this into like it's the GP's job to just do. It's not my job to justify anything. I'm here to promote the health of patients. And that's all I'm interested in. This conversation hasn't been about how we're going to do stuff differently. I think what we're saying is there's a way the government could do this more effectively. And then I think the bit I'm trying to do is, and at my practice, we've done this. And so this is doable. It's not airy-fairy. It's not pie in the sky. And it's just trying to make it a bit relatable. So, for example, a lot of what these guys talk about is good. But then I'll give you an example of why we don't do birthday recalls, right? So when you initiate a change, and this is where I feel like people don't have sense, right? So anything that is done between December and March, which is a third of the year, right, is not going to be effective in terms of chronic disease management. Because whenever you make a meaningful intervention, how long do you normally leave before seeing if that thing has achieved something? It's normally 3 months, right? So if you were to see someone in Jan or Feb, and you're trying to make some intervention, that review is going to take you past March. But from a funding perspective, your funding is attached to that financial year. So you've kind of got to do all of your stuff before November, which is why we developed the model of April to October, of that, because if I do something in October that requires meaningful intervention and I then need to follow it up, I've got January, Feb to get it done. Do you know what I mean? And if I don't do that, because I think about it, a third of your patients are going to have a birthday between December and March, aren't they? The first thing is I don't like the concept of somebody coming into their doctor on their birthday or around their birthday. It's such an odd concept to me. I would pick any month that's not the birthday month. Do you know what I mean? On birthday. So I deliberately say the month after or the month before or something. So there's loads of issues. What is the profession asking for, and what is it actually doing?
Yeah, but it's a good point, because I remember when I was in med school, it was kind of unprecedented times where doctors are striking for the first, and now it just becomes the norm. Like another strike is being announced, and I'm sure, again, I'm seeing it from both of it. I'm seeing it as an active GP, as a clinician, but I'm also seeing it from a patient's perspective, because I've got family members that keep asking, "Oh, there's another strike. What's going on?" And so it's quite an important thing to consider. And again, I'm just reviewing things that we were kind of talking about just now. Is what are we as a profession asking for? And in essence, what are we getting? And really, you touched upon it. Are we technically making the most of what we're getting?
So let's quickly summarize what the profession. When I said the profession, I mean GPs.
Yeah.
Right. So because we have to be very clear that there are different roles in primary care, and they kind of all want fairly different things. Right. And everybody's gonna. I don't think it's rocket science that everyone's going to look after their profession's interest. Correct.
Yeah.
So what are the GPs asking for? The GPs are essentially saying we need more funding, which everybody would agree with. They're saying we need more GPs. I don't think anybody would disagree with that. They're saying GPs deliver good care. I don't think that's going to get debated. The bit that we don't talk about is what should a GP do and what should they not do? What things are best done by other people? That's a conversation we don't seem to be having. And what the government seem to be very clearly showing us is they want less GPs. And I don't think this is controversial, right? I think the government's been incredibly clear in not increasing the primary care funding in its core contract, which is how you would get more GPs, right? So they haven't been increasing that. And anytime they have given a slight increase, it's almost exactly matched with a pay increase for the staff. So essentially they'll say something like, we're giving you a 5% pay uplift, and then there's like a 5% staff waging. So, they love to tell us how they're giving us a pay increase and then immediately give it to everyone in the practice. So you can't really get anybody new with that money. Yeah. And usually, actually, and this is a little nuanced point, the funding increase that they give us is usually not enough to cover the funding that they've said they're going to pay the staff with. And I'll give a very quick, because this often gets misunderstood. They'll say we're giving a 5% increase to the practice. The staff are also promised a 5% increase. What they don't tell you is that the practice is a business. So as a business, you have not only the employee cost, but you have the employer cost. Yeah. So if this person is getting a 5% increase and we've been given 5%, who's going to pay the extra national insurance and pension employer contributions for this person? Who's supposed to pay that? Because the government don't give us that, right? So what ends up happening is this 5%, 3.5% will become their pay increase. And that 1.5% is just to cover the employer cost for that employee. So just to break even, we have to segment the funding just to cover their costs. And by definition, they will never receive the pay that's advertised, because the additional, what would have made a lot of sense if they said, when we do a pay increase to primary care, HMRC will forgive any associated employer tax costs, because we're trying to get all of this money into this person's pocket. Yeah, that would make sense, but we don't do that. So there's a bit of game playing there. Separate to that, what they do is the money that is being made available is being pumped into community pharmacies, which I think has its merits, right? And we can talk about them. And it's being pumped into primary care networks, which I think has its merits. Now, in a community pharmacy, have you ever met a GP? No. Right? So obviously you've got dispensers, you've got ACTs, you've got pharmacists. And when you go to a PCN, for the majority of time PCNs have existed, there has been no GPs, right? It's been an allied healthcare professional workforce. They have introduced GPs more recently, and they love to talk about how they've increased the amount of GP numbers. And what they're talking about is the amount of PCN GPs. So out of interest, what's the criteria to be a PCN GP?
Well, it's quite restrictive, isn't it? You can never have a salary job beforehand, and you have to have qualified within the last 2 years.
Yeah. So what we're describing there is a newly qualified, relatively inexperienced GP, because by definition you have to have been less than 2 years qualified. You could have never had a substantive job. So what that means is you have never been a long-term part of an employed role. So you've never been a salaried doctor. You've never been a partner. So you could have only ever been a locum, right? So if you were a locum self-employed person, you typically, and I'm not saying this is for everyone, but I'm saying 95% of the time this will be true. As a locum, you typically deal with acute demand. Yeah. Right? Because when somebody needs somebody on the day as an emergency,
they'll call a locum.
It is not to deal with their super complex, multi-morbid patient. It's because they've got 30 sore throats and sick notes and relatively simple things that need to be addressed, where the continuity factor isn't a problem, right? Because when you have super complex patients, continuity becomes more relevant. So what these PCNs have ended up as is very acute demand. And like, look at the wording, right? When you have an MSK practitioner, so a physio or an MSK specialist, the word we use is first contact.
Yeah.
First contact physio, right? First contact practitioner, which means when somebody presents for the first time, send them to the PCN. So these models are becoming acute care demand models. So it's a place to send urgent requests, probably so that they don't clog up A&E or the out of hours or the walk-in center. That's likely the bit that we're not talking about. That's probably why it's happening. None of these models are designed to give any sort of meaningful preventative intervention. The most sort of productive, meaningful thing that's happened that I've seen from a PCN is the structured medication review, which is for the frail patients, dealing with people that have in the care homes, in the nursing homes, very, very vulnerable, lots and lots of meds, rationalizing their treatments. That's very, very proactive. But I would argue when 40% of your R's budget in most PCNs is spent on a pharmacist, you would hope that there's some level of
medication reviews going on.
Medication reviews happening, right? Because otherwise, what are they actually doing? So that's a given. And I think, in all honesty, the pharmacists and the physios have been invaluable. And I think primary care has learned how to fantastically make use of these two roles, especially. And the rest of the roles is very like variable and really, really adjustable. But when that's the multiple millions the government has pumped into the system, to me, it's not realistic to then turn around and say, ignore all of this that you've done. Now put loads of money into practice. They're not going to do that. They've look at what they've done. They're going to continue to fund this model because that's what they believe is correct. And I think there's a huge disconnect in what I think would make it a lot easier is if the government just said, we don't believe the way we've been doing this is correct. We think this is the new way to do it, and this is the way it has to now work. The problem we have is these decisions are made on an annual basis. So for the last 3 years, every year there's been this thing of our PCN's finishing, our PCN's finishing. And so people have been working 1 year at a time. So they're always guessing if the next round of funding's coming, and that prevents any long-term planning, which is a real problem. If they just said for the next 10 years, this is what's going to happen, work with it, it would have made it so much easier. There would have been so much more continuity. There could have been better business planning. But I guess the point is there's a disconnect between what GPs think we need and what is actually being delivered.